Hey, welcome everybody. It's always a pleasure on Monday to welcome in our guests from Community Medical Center. Today we're welcoming Dr. Elizabeth Sue, and you're special. You've got a friend here with you as well. So would you introduce your friend? First of all, welcome to you. How are you, doctor?
I'm good, thank you.
Good. Who is your friend?
My friend is our breast health navigator at Community Medical Center. Her name's Ronnie Nelsen. She's a registered nurse.
Fantastic. All right. So first, I want to let folks know that the lines are open. If they have a question about breast cancer, which I know everybody does, 721-1290 is our number. Dr. Sue's here to take your kind of general information calls. Nothing real specific, but just to give you general information. Would you just tell us a little bit about yourself and how you got to Missoula and how you got involved in breast cancer in the care that you provide?
I kind of grew up in Southern California, and then I did my surgery residency in Tucson, Arizona at the University of Arizona. And then I had a practice there for a few years, and I just had a liking and a special interest in breast surgery. Moved here in 2002. And I've been practicing in this community since then and really focusing more on breast care.
So 14 years you've been here.
Seems like
wow.
Just yesterday.
It's amazing. So what was it specifically that brought you to Missoula?
I would have to say it was friends. So I have a few friends that we met in Arizona, and we were visiting prior to moving here a few times a year and decided to make it our home.
And who wouldn't want to live here? I mean,
right.
as opposed to Arizona when it's like, 400 degrees in the shade, right?
Right.
All right. So, Ronnie, let's talk to you. Tell me a little bit about you. Raise that microphone up because you're a nice and tall lady. Okay. So tell me a little bit about Ronnie. Where'd you come from?
I was pretty much from Missoula and started my nursing career here at the University of Montana. I finished my RN last year through Excelsior College and headed on to my master's because I just keep going to school.
There you go.
And I started with Dr. Sue about 5 years ago and just kind of stepped into the role of nurse navigator in the last year here.
Now, if you wouldn't mind describing what a nurse navigator does. I mean, the title seems pretty self-explanatory, but fill us in.
Do you have like an admiral cap that you wear?
No, not.
Ahoy, matey. Yeah. Anyway, I'm sorry. Go ahead.
Right. So we're kind of the point of contact for the patient at any point during their breast workup, whether it's just they're having a biopsy or maybe they've had a diagnosis or they need help figuring out how to pay for their mammogram or anything like that. I'm just like the one-stop shop for how can I help you with your breast health. Okay. And then I do a little bit of genetics education as well. So
genetics education.
Yeah.
So give us just like a quick when you do a bit of genetics education, what do you tell people?
So I'm not a genetic counselor, but I can take a pretty thorough family history and kind of give patients an idea of, are you at high risk? Do you need to see a genetics counselor? Is there genetic testing that we should be worried about? And a lot of times patients that think they're high risk might not be. So we can run a screening program on them and give them a percentage. And sometimes we make them feel a lot better and they can just resume annual screening instead of being concerned about their risk.
And is this something you walk people through after they've already been diagnosed with something, or is this like a pre-screening before they ever get involved with cancer treatment or tumor reduction?
Hopefully we're in the pre-screening phase, trying to determine what risk group they fit into, whether they're in the low risk and they can just continue annual mammograms and breast exams, or whether they need more further workup.
No, Dr. Sue, if you would, I wanted to ask you a couple of questions. I've been around for a long time. I'm significantly older than you, and if I remember, the whole fight against breast cancer has been going on, especially as a very high-profile fight against breast cancer for many, many years now. How close are we? Any closer at all than back in the 60s or 70s today than we were back then to actually finding a cure and a really effective treatment for breast cancer?
I think cancer treatment has improved significantly, including targeted therapy, different types of chemotherapy, if that's warranted. But I think the big push really is the surveillance and the preventative screening. I think the education's out there and people are a lot more aware to come in sooner if they have breast concerns. And that's the reason why we developed Montana Breast Health at Community Medical Center. That program actually was created by a steering committee made of multiple doctors, and we all felt that we needed a program where a patient could call in with a breast health concern and have an easy access resource to get those problems evaluated efficiently. And that includes primary care providers in the region. They can contact us, and we sort of kind of absorb those patients and then guide them through the problem and figure out whether it's concerning or not.
So is Montana Breast Health like a call center, or is it like a big room with different equipment in it, or what is it?
That would be really cool, but it's no, it's
It's in a van down by the river. No,
the introduction to Montana Breast Health for most patients is when they come into, let's say, advanced imaging for their screening mammogram, and we try to address mainly a family health questionnaire to and kind of get them interested in their high risk screening, and that's when it starts. If those patients become a concern for an increased lifetime risk for breast cancer, then that's when Ronnie comes in and we do some genetics education and see if they meet criteria for genetic testing in case they fall in a really high risk group because of family history or personal history. And then Montana Breast Health is also about those patients that continue going on if they have a breast concern that turns out to becoming a biopsy and unfortunately becomes cancer, then we can help guide them through that process as well.
Now, is breast cancer primarily genetic, or are there certain activities and things that we do that can exacerbate or make it more possible to get breast cancer?
Yeah, so breast cancer is primarily not genetic.
Okay.
And
Right.
actually the people, and that's one of the things the high-risk screening program does help with patients to give them a peace of mind, because there is a small percentage of patients that actually carry gene mutations that put them at extremely high risk. But things that we can do is educate those patients about, good diet, minimizing those toxins like alcohol, smoking, those kinds of things. And those things do make a difference. Unfortunately, we don't know what, there's not one cause that causes breast cancer. It's probably multifactorial. So we primarily focus more on education and early proactive behavior, just so that people get in for screening on a regular basis.
Is all cancer the same? So my grandmother, she had cancer and eventually died from it, but she quote unquote beat it 2 or 3 times before eventually passing away. And I remember as a child, they told us that she had a different type of cancer, but it was in the other breast. So I was really confused why they didn't just call it breast cancer. I was wondering if you could kind of explain if there's a difference in the type of cancers that occur.
Well, there's different types of cancers of the breast and where they originate from, but generally we kind of label them as breast cancer. Now, there's rare situations where other tumors can spread or metastasize to the breast, but that's probably not as common. But some people can have one breast cancer, get treatment, basically cured, no problems or relapse within 5 to 10 years. And then there are some patients that may be in that higher risk category that develop a new primary breast cancer.
Now, how much of that has to do with the lymph nodes? Because I know that it's very close to where the breast is located. Does it start out to be lymphatic cancer and spread, or vice versa, or what?
Well, usually the breast cancer originates in the breast, and as it continues to grow there, then it can spread to lymphatics. And then once it spreads to a lymph node, then there is a risk of disease elsewhere in the body. And that's when those systemic treatments like chemotherapy and hormonal therapy become very important in treatment.
Okay, we're up against our first break. Phone lines are open. Dr. Elizabeth Sue and Ronnie are both here. Ronnie, Nelsen, both here with us to answer your questions. So if you want to talk about breast health, breast cancer, maybe you've got a question about how often should I get a mammogram? I'm over 50, under 50, whatever. She's here to answer your questions. 721-1290 is our number. This is Health Talk, and we'll be right back. Oh, yeah. The doctors and medical personnel are allowed to boogie to the bumper music. All right, 721-1290. That's how you stay healthy, see? All right, keep moving. All right.
The biopsy boogie.
Yeah, no, nothing like that one. All right, let's get to the phone. Tanya is standing by with Dr. Sue. Hi, Tanya, what's on your mind?
Question for them is, what role does estrogen dominance play in the formation of breast cancer, and how would a woman circumvent that before it became an actual problem?
So, estrogen therapy and so forth, like hormone replacement therapy, probably doesn't play a significant role except for if you're taking it well beyond the normal age of menopause. But most breast cancers do have estrogen receptors and are responsive to estrogen, and that can stimulate the disease. But there are some that don't. But in most situations, we don't recommend estrogen depletion in patients that are necessarily even high risk. Might have had a biopsy that showed something that was precancerous even. We just recommend surveillance and follow-up. There are some people that fall into a high-risk category with some atypical cells, and if they have an abundant amount, sometimes we do recommend some kind of preventative anti-estrogen therapy.
Does that help you, Trace or Tanya?
Sure, thank you.
Okay, thanks for the call. All right, so we have 4 lines open.
So when people, I mean, everybody's thinking about the different things that they might do in their lives that might lead to cancer. You mentioned smoking and alcohol and some other things, but do we really know much about what causes it other than, and you said it wasn't genetics, so that leaves a whole basket of stuff out there.
Yeah, there's probably still a lot unknown, unfortunately, but we do know that early detection is the key to cure for someone's lifetime. So we try to get that education out there because that's probably the most important. People can actively pursue that and be very forward thinking about, okay, I have to get my mammogram every year and a good clinical breast exam, and realize that is a very important step in cancer prevention.
So when we see the Susan G. Komen, like the Race for the Cure, every year there's like millions of people take advantage of that. There's the big cancer walk. There's at the University of Montana they have a big cancer orientation football game. Everybody wears pink. The money that's raised through those, where does that go? What exactly does it do? Do you have any idea? Because I know it's a national program, not necessarily tied to you guys, but that's a lot of money is being raised, and we're hoping that it's going towards something really important.
Right. Well, I think a lot of those bigger fundraising societies, actually, there is a certain amount of money that does go to working on cures for breast cancer, but detail-wise, I'm probably not the right person to ask.
There's 2
Go ahead,
local organizations here in Missoula. There's the Ava Nicole Foundation that helps patients pay for their screening workup and anything kind of breast-related. And then there's also Team Up Montana, so the parade you're talking about at the university. They help with similar things, and they help the cancer patients with some money when they get diagnosed. So all of our local patients here in Montana can apply to either of those foundations to help them with either workup or their cancer diagnosis.
Now, I have a dear friend who is a 2-time breast cancer survivor, okay, and she's had a really rough time, and but she seems to be okay now. What are the variables that cause to that returning? In other words, is someone who's had it once more likely to get it again, or are there any numbers that you can point to on that? So, Dr. Sue.
Well, it all depends on the stage and how advanced their breast cancer was on their primary diagnosis. But if somebody's been through therapy for their primary breast cancer, the risk of recurrence is actually very low, but it depends on their stage. If somebody has had breast cancer twice and there are actually 2 new primaries, meaning that they're separated, one person's had an initial cancer treated, and then it's been 5 to 10 years later, and they have a new primary that's different in a different location, different area of the breast. And sometimes those patients are people that we actually say, you need probably some genetic screening. We need to really look at that because those people, 2 breast cancers in their lifetime, could be at high risk life term. So,
and if you find that you have some genetic disposition to it, it's just going to mean more regular mammograms, or what? Is there any treatment to it?
So the biggest genetic mutations that have been carrying a significant high-risk lifetime, despite whether you've been treated and diagnosed with breast cancer once, are the BRCA1 and BRCA2 gene mutations. And those risks are about 87% ongoing lifetime risk of breast cancer. As far as ovarian cancer, can be as high as 46% ongoing lifetime.
Now, I know you assume a lot of us probably, but we don't know what the heck BRCA1 or
right.
1, 2 are. Are these just the genetic combinations?
Ronnie could probably tell you a lot more about that, but they're genetic mutations or deletions, and these are ones that are hereditary, so they're carried down and passed on. So they're probably consisting more of that 1% to 2% of all the breast cancer diagnoses we see.
Now, is that, I know Angelina Jolie was a very
Right.
high-profile person who discovered she had this genetic thing and went ahead and had the double radical mastectomy, right?
Yes.
So does that happen a lot, or is that very rare?
We follow a lot of BRCA1 and 2 patients. A lot of times they get diagnosed because their mother or, they've found out somebody in their family may have had it. And so we test them. It doesn't mean that you have to have aggressive surgery right away. But when, like for Angelina Jolie, you take somebody who has a BRCA1 or 2 mutation and an 87% ongoing lifetime risk, and you do bilateral mastectomies on them and take out their ovaries, you've actually decreased their lifetime risk of breast cancer down to about 4%, which is actually lower than the normal female general population.
So taking someone's ovaries out reduces their risk of cancer.
Ovarian cancer.
Of ovarian cancer. Oh, right, because they don't have the ovaries anymore. It makes a
Right.
lot of sense.
But that is a rather severe step, is it not?
It can be severe, and to start with, when we start screening patients, a lot of times it's the offspring of patients that we've seen, and these patients are diagnosed that are premenopausal, let's say in their 40s, so they have children in that are teenagers or in their early 20s, and it's not recommended to do surgery right up front, but we follow these people, and they do actually, insurance companies do authorize frequent surveillance with MRIs every year, as well as mammograms and clinical breast exams. So we follow them pretty closely to take the worry off of them so that someone else is having to worry about it and not the patient.
Does pregnancy incline one or disincline one towards having breast cancer?
Pregnancy in itself does not, but there's been a lot of things like whether or not you get pregnant at a later age and so forth. Is that a risk factor? It's probably not as significant as we once thought years and years ago.
Okay. All right, we're up against a break. When we come back, we'll have like 3 minutes. So I want to get from both of you some things that we can do, both men and women and men, I should say, to make sure we not get breast cancer, what's tips that we can do, tests we can perform, all that good stuff. Can we do that when we come back?
Sure.
Okay, we'll be right back. We still have some lines open, 721-1290. Dr. Sue will only be with us for about 6 more minutes. If you have a question, give us a call. Okay, we are back on Health Talk. Health Talk rather than Talk Back. Dr. Elizabeth Sue and Ronnie Nelsen both joining us. Okay, we have like 3 minutes, so let's talk about prevention and how we can keep this from happening to us. So who wants to jump in there? Ronnie or Dr. Sue, either of you guys. Go ahead.
So what I would like to get that word out is most people think that just a screening mammogram suffices for their annual surveillance, and I really push for clinical breast exams. There's many patients where a mammogram can be normal, but their exam could be abnormal or actually start leading you down a path of further surveillance with other imaging tests. So I think that's the most important.
Can you give me some understanding of why? Like when I think of a mammogram, I'm thinking you've got this like three-dimensional picture of what's going on inside. How could you possibly not see what's going on inside?
Well, there's a lot of differences in density and how that breast tissue images. And some people, especially younger patients, have a lot more dense breast tissue. So we're looking for white things that can stand out like calcifications. And if your breast tissue is dense, it's going to be closer to white. So those can be harder to detect.
But you could maybe feel them? Is that what you're saying?
Some tumors don't actually lay down a lot of radiological scarring or imaging that may be suspicious, and it may be more of what a distortion looks like, a smear on a mammogram. And they may present with a very large mass. So some tumors don't actually show up first on the mammogram, but actually present as a mass.
So how often should a woman get these tests?
I recommend clinical breast exams every year, as well as an annual screening mammogram starting at age 40. Typically, and a patient doesn't have a family history. If they have a first-degree relative that does have breast cancer, then I encourage probably a first baseline and an exam at 35.
Okay. So, Ronnie, any tips on how we can keep ourselves healthy so we don't get this?
Navigate us out of this half hour here.
Just recommend getting regular exercise, maintaining a healthy weight. a good healthy diet. And then if you're concerned about your risk at all and how often you should be getting your mammograms, just seeking out your primary care provider or Montana Breast Health to help you figure out your risk and what you should be doing every year. So
how about some contact information for you folks? If folks want to get an exam or want to get in touch with the breast center, what do we do?
You can just dial 327-3943, and it'll get you right to our front desk, and they can get you to me or Dr. Sue, and we can get you an appointment. I'm always available. I'm there 5 days a week. Answer any questions you guys might have.
Real quick, the genetic screening, is that something only associated with the breast health, or is it something basically for anybody?
So I just do the breast health as far as genetic education. If you're worried about other cancer risks or things like that, you're still welcome to call that same number, and we work with a genetic counselor at a Billings clinic that can help you with any sort of cancer concerns as far as family history goes.
All right, Dr. Sue, Ronnie, thanks for being with us. You guys did great. All right, excellent. And thanks for your phone call, by the way. And we'll do this again next Monday right here. We call it Health Talk. We've got folks coming in from the University of Montana for Talk Back here in just a moment. Stay with us.